Thank you so much for having me in this ginormous room today. I was asked by Dr. Alu and Dr. Mesler to talk about the need to establish standard training curricula for HPB fellowship training globally, which is a daunting topic. And I promised Dr. Mesler I'd bring up some controversies because I'm not shy of them. So first of all, I do have some disclosures, and I'm honestly happy to have some more if anyone wants to come talk to me afterwards. So I think in understanding where I'm coming from, it's important to know my personal story. And then we'll talk about why accreditation in HPB surgery is important to me, and then mechanisms to gain accreditation and where we can go from now. So first of all, this is my story. University of Chicago, did 1 year of a transplant fellowship. I call myself a recovering transplanter, and then went into traditional academic practice, and then sort of fell from grace in 2005, and actually thought my life was over when I went into private practice, because I had that radio frequency chip implanted in my brain that, the University of Chicago tends to do. And what I tried to do in that environment was to build the best of academics outside of academics, and honestly to get rid of some of the things that we don't enjoy about academics, including some of the power struggles and ego struggles, etc. In 2016, this was another little inflection point in my career because I moved to a different hospital within our system, which allowed me really to rebuild a program using the elements that I had learned already. And really, when it comes to training, I call myself the roadmap to peace, right? Because I partially trained in transplant. My practice is a lot of surgeonc in that I still do gastric cases, esophageal cases, rectal cancer even, and I have an HPB fellowship. So I kind of think that I understand a bit of all of these things. And my sort of, those of you that know me knows that I'm all about building bridges and not walls. And so I spent my life and my career to try to bring the best of each of these to training. So this is the three of us in our group. I'm really blessed to work with two people that trained with me, and we say yes to everything, which is kind of nice. Perforated esophagus, yes. Diverticulitis, yes. Pancreatic cancer, yes. And why is accreditation important? This picture shows you a posterior sexual duct that's disconnected, so this is the kind of thing that we get called about. And really, we're talking about such high-end surgeries, right, that have such major complications, as Dr. Alu pointed out in her opening slides. So really, talking about the US perspective, we are so siloed, right? Especially in the academic world. We have transplanters, we have surgical oncologists, and we have HPB surgeons. And the question is, and just to point to my two chairs over here, they're just brilliant examples of how they've been able to bring all of those elements together under HPB. And these are the ways to train in the US. There's the transplant training route, there's the SSO training route, and then the AHPBA training route. And my passion is, let's all get together and figure out the Venn diagram and where does HPB fit under each of these that we can learn from each other. So just a brief comment about each pathway. The ASTS pathway separates HB and HPB. All of the accreditation for these pathways are housed under existing liver transplant fellowships, and they're accredited independently but by related entity to the ASTS. This is a very sort of small slide, and I can provide this to anyone, but it basically shows you the HB and the HPB training criteria. But basically, if you look at the fellow volume requirements, the previous slide was the program volume requirements. It's 45 liver transplants, multi-organ procurements, and then the additional cases for HB and then HPB over a 2-year period. The SSO pathway is a 2-year pathway. It's ACGME sort of stamped these days, and focuses on the principles of the management of the cancer patient and focuses on the multidisciplinary aspect. And these are the sort of updated guidelines with regard to really looking at the complex care of the cancer patient And really, one thing that I really like is the ability to lead a tumor board and understand each of the disciplines that go into making up that tumor board, which I think is a great aspect. These are the case requirements, and if you look at the GI, at the HPB requirements, they're 35 cases over a 2-year period. So very different, really focusing on, the multi-D aspect. And then if you look at the AHPBA pathway, it's 1 or 2 years, accredited through the Fellowship Council, and now under the guidance of Dr. Adnan Al-Saidi is international with the South American fellowships. And a busy slide over here showing the progression to where we are right now. I can't even see this very well myself, but we've included things like under liver, pancreas, and biliary tract, but then ultrasound requirements and MIS requirements, etc., with a very robust set of guidelines. So what do we mean by diversity in training? Well, we can see that each pathway emphasizes different elements. Transplant looks at the sort of what you gain from doing the liver transplant procedure itself. But we can see that each product is different. And really, is this okay? So what is implicit bias? Because this is the philosophical portion of this, right? We all will automatically and unintentionally gravitate towards those people that are like us. And that also means trained like us. But I would say we need to face the facts, right? That we need to favor those that we tend to favor those that trained like us, and we default to that situation under stress, which can be even being at a meeting and at a podium. So what can we do about this? Well, why don't we look at what's good in other ways of training? Let's look at the elephant in the room, right? Some people will say that transplant is very technically focused. CGSO is all about chemo, and HPB trains surgeons that are non-academic. Well, why can't we instead flip that and say, wow, I wish I could sew in the portal vein like Dr. Molinari, who does it day in and day out. I wish I could look at the data like my surgical oncology colleagues and really understand it. Or why can't we be investigational outside of the ivory tower of traditional academic medicine? We try to do that. And so let's recognize our differences, let's appreciate our differences, and let's learn from our differences. So for me, the ideal team would be one of each, right? That would be great. I would love that. I wish we could get there. And I wish we could look at the power of the other. So this is also what I love, and this is what I tell trainees. You want to do HPB? Well, look at the other. In CGSO, you're going to be doing melanoma, breast, and other GI things. In transplant, you're going to be doing things like kidneys, livers, and vascular access. In HPB, you'll probably be doing general surgery as the other. And what do you love? So as we look at this globally, figure out what is the best pathway, but take the best from each, work towards that center of the Venn diagram, learn from each other, and welcome each other rather than being defensive. I mean, right now, we're dealing with DEI issues. This is one of them. So we can get through the LD50 during our training curve and take care of the patients better. I always say, look at what we did with lap chole, right? We got past that 40 inflection point during training. We probably need to get past that 60 Whipple inflection point during training. So as Dr. McClellan said, who unfortunately passed away a couple of years ago, he took care of JFK, the day I stop learning is the day I hope I roll over and die. Roll being the wrong roll here. I'm sorry, it should be R-O-L-L. And I just wanted to thank you, Dr. Elu and Dr. Mesler, for including me in this. I'm a nobody, but so honored to be here to share some of my thoughts and insights. Thank you so much.